I'm John Houston, and I am the CEO and founder of Dual Arms. I've always been kind of a closet inventor, just never had the right market. I started noticing I was losing my voice around 2000. During that time, I probably had 55 or 60 exams in my airway. It's a challenge for the patient. It's a challenge for the doctor too. Dr. Simpson and I have been working on a clinical trial that we could make that post-surgical procedure or pre-surgical procedure more effective. And not just for the patient, but also for the doctor.
The PrepAir device vaporizes lidocaine, and that lidocaine is used with an endoscope to actually numb the anatomy as the endoscope goes down into the airway. And that way, the body doesn't understand that there is an intrusion and doesn't react against it.
When John Houston came to us and asked us to develop the project further, I was really inspired by the idea of getting to help patients who are having a really hard time with this specific procedure and really getting to change how they would experience something that in some cases could, drastically affect their lives. The innovation is in the nebulization of the lidocaine. That's what affects the patient's ease of use.
Wax that you put on your cardigan after you wash it, and it's bubblegum.
Audio Jungle.
Hi, I'm Dr. Blake Simpson, professor in the Department of Otolaryngology at the University of Texas Health Science Center in San Antonio and director of the University of Texas Voice Center. The biggest problem with the procedures that we perform on these patients is their lack of tolerance of it. When we administer a local anesthetic to anesthetize the larynx, the problem with most patients is they cough and choke and poorly tolerate this procedure, to the point, in fact, I have many patients that have told me they avoid coming in to see me because of the side effects from the numbing process. And so what we were seeking to do is come up with a more readily tolerated numbing process, one that so far did not exist. I think the problem with the procedure where you anesthetize the patient is it's traditionally been done the same way probably for the last 40 or 50 years. And it's kind of just become accepted that that is the way that you must anesthetize people, and that's basically to drip the numbing medicine on their vocal cords. The problem with that is it's like aspirating water. It's like swallowing the wrong way and having it go down to your lungs. There's coughing, there's choking, and I had some patients describe the process of numbing them as waterboarding. So that should tell you how poorly tolerated this is and how much dread, frankly, there is when we have to anesthetize these patients. So I've had the opportunity over the past probably several months to use this system in a clinical trial. So it's being rigorously looked at in a scientific way. And I can say without a doubt it's been a success. The patients have tolerated the procedure well. They've been adequately anesthetized to be able to tolerate the procedures, and virtually everyone that has had the old way done and the new technology prefers the new technology. If I were to describe the current process for numbing patients, I would describe it as torture. And if I were to describe the new process that John has developed, I would say salvation.